All right, so there were a number of abstracts that were presented this year. We're analyzing patients who have had long survival, and so it's interesting to understand. So in the first broad perspective is this linked to the MRD negative? In other words, do all the patients who have a long survival, are they MRD negative, or maybe some are MRD positive and doing just well? And so it was interesting to see several studies, and one from the Mayo Clinic where I show the data here. They broke the patients into a number of different groups, and they were able to show that patients who had been in continuous remission for over 4 years without having ever had a relapse, they have the best survival. And this could be with ongoing continuous therapy or even off therapy. If there had ever been a relapse, then those are the lower curves here. And so a couple of other abstracts looked at other aspects of how could you predict which sort of a patient might have a long survival. Actually, the Spanish team again were correlating with the presence of the MS signature, which can be an indicator of longer survival. And so to kind of put this in perspective, there's a paper just recently published from our IMWG where the baseline, I think that we tend to forget that the baseline for long survival, even out to 20 years, is not zero.
Yeah, which is good.
Which is very good. The starting point is not zero, it's a little less than 15%. And so we are starting with that, and with the newer therapies, we're expecting that number to go up sequentially, and it could be with MRD negativity, or maybe not always with MRD negativity. Yeah. One other abstract showed that obviously the likelihood of long survival is linked to a lower age, the absence of low platelets, CR after stem cell is obviously very good, and as you might expect, the use of the more novel agents, and especially maintenance, is an important aspect. And so we need to be thinking about where are we in terms of functionally curing or really getting to this point where patients can really live a long time. Are we starting to have some aspect of cure in myeloma moving up above the 15% level? So obviously, Mary V, you have the initial results with your CAESAR trial in the high-risk smoldering setting. And so what do you think is the status right now?
So I think that in order to increase this 14.37% of patients
yes.
potentially cured, I think that beyond these patients with the long remissions, I think that we can potentially increase early detection and early treatment. And as you mentioned, in our CAESAR trial, so we planned an active therapy for high-risk smoldering myeloma patients, and the objective is to cure patients. Yes. And so we planned the definition of cure as sustained minimal residual disease negative at 5 years. Of course, the median follow-up now is short at the present time, and we have to wait. But so we can positive results, and in fact, so all patients included in the study had already completed the induction, the transplant, and the consolidation, and 55% of patients after transplant went in minimal residual disease negative. Yes. And we are going to evaluate right now the proportion of patients in MRD negative after consolidation, and most patients are now in the maintenance phase. So I think that you are going to complement our study with the ASCENT study,
yes.
And we will see. But also I think that beyond these long remissions, I think that there are patients in minimal residual disease negative, and I think that MRD negative is a good surrogate marker predicting progression-free survival and overall survival, but not all patients achieve MRD negative, and there are some patients that are long survivors in spite of the minimal residual disease is not negative, and I think that in these patients the immune profiling is critical.
Yes.
Because I think that these patients can potentially have what I can say a positive immune profiling that is able to control the disease although the tumor clone is present, so a good immune system is able to control the disease.
Absolutely.
So, and I think that these three pillars so would be responsible for achieving more patients potentially cured. Early
Absolutely.
treatment, MRD negative, and if the MRD is not negative, immune profiling and to try to maintain the immune system
to
stimulated.
maintain it, yes, yes. So I think these are the key points, and I think, and Joe, we're going to have to move on, and you could comment on some similar aspects in this next final segment here, but I think that, yeah, these are really key points in terms of how we stand in attempting to cure patients right now. And you're interested in the CSER trial, and we're certainly interested in the outcome on the ASCEND trial.
Absolutely.
And so, in the assessment of MRD, it has been quite interesting to see what has been the longer term outcomes with these combinations that we've been talking about, DRD and DVD, in the relapse setting, the CASTOR and the POLLUX trials that were quite exciting data at last ASH and the ASH before. And so at this ASH, what we have is the longer term follow-up of these patients. And so what I think was quite interesting for me, I'll be interested in your thoughts, was that patients who had MRD negativity at 6 months, in the POLLUX study, for example, DRD, you can see at the top there, sustained MRD negative, doing very, very well in terms of PFS and overall survival. And then similarly for the Dara-Velcade DEX, MRD negative at 12 months. For both of them, 6 months and 12 months, quite impressive in terms of sustained benefit in remission and overall survival. And so it really puts the question strongly, should we really be attempting to achieve that in the relapse setting? And so, Joe, maybe you can comment first on this part.
Mm-hmm. Yeah, no, I mean, I think it fits with what Marie-V has said. I mean, I think in general, depth of response correlates to duration.
Yes.
In majority of myeloma patients, there are probably patients at either extreme in whom that does not apply. The very low risk, as you've almost described, that MGUS-like signature where the immune profile, I mean, we have some very long-term survivors of myeloma who've actually never had a complete remission, let alone be MRD negative. But again, that's a pretty small fraction. And similarly, the other end, some really high-risk patients who may transiently go into MRD negativity and then it goes away. That's why I think this data was so important to show that a prolonged sustained MRD negativity is going to be important.
It really is what makes a difference.
And I see us going in the strategy that Marie-V has described, that even though we get very excited about risk stratification, it seems that that's just step one. So what is patient high risk, standard risk? But after they get treated, if they're in MRD negativity, we have maybe more comfort in not treating them as aggressively. But those MRD positive patients probably do need more.
Alternate
if the
therapy.
Immune profiling is such as you've described it, they may need a different class of drug or a different approach.
Yes.
And so
maybe the CAR T or the bites.
Correct,
Yeah,
especially in the
exactly.
highest risk patients. So I think we will probably get to a stage where we're saying that MRD negativity will influence your next step. If you're MRD negative, you know, from the upfront setting, I know this is a relapse setting, you might say, okay, we'll go on to lenalidomide maintenance. You're still MRD positive, you're going to have a poor outcome. Now is the time to say,
jump in,
give in something
and
CAR
do
T
something decisive.
Correct.
So
Yeah, I absolutely agree. And so concerning your specific question, I think that MRD negative is also important at relapse.
setting.
Not only in the upfront setting, because so now we have combinations like in the POLLUX, in the CASTOR, but other combinations very effective at relapse. And so patients can achieve a complete response. So I think that it's important to evaluate the quality of the response and to evaluate the minimal residual disease, because we have had the opportunity to see the first time how the new criteria described by the International Myeloma Working Group, sustained the minimal residual disease negative, was evaluated in both POLLUX and CASTOR, and really sustained the MRD negative related with flat in terms of PFS.
And these are actually the criteria summarized in the new criteria. So this is tremendous to see validation of that. So let's just go to the last point. So hot topics that might have been missed. So obviously there was some data on venetoclax, some follow-up on selinexor, which I think will probably be the next agent which is approved, FDA approved, probably based on the STORM trial, the Boston trial, some of the other combination trials, and a very new drug, melflufen, where there was some early data, also some interesting data on elopalm, which was actually recently published in the New England Journal. And so the melflufen was just interesting. It's a very unusual alkylating agent where some very preliminary data. So it's interesting to see a new agent that you haven't really been expecting, maybe showing some interesting results. So something just to be aware of, that it was producing some early benefit. But really, are there any other topics that you would think that were interesting or important that you heard this year, Mary V? You're at the top of the list here.
So I think that we have almost covered. I think that all aspects, just so mentioning the new agents that you have showed in the previous slide, selinexor is important, because I think that is a new agent with a different mechanism of action,
right.
What I think that is interesting, and so it has demonstrated to be effective single agent in combination with dexamethasone. And concerning melflufen, so I think that we are now to treat our patients in the beginning without alkylator, and so maybe transplant for patients who receive autologous stem cell transplantation, and maybe we are going to recover new alkylator melflufen at late advanced stage of the disease.
Yes.
And melflufen, so is a new alkylator. It has a different mechanism of action to the conventional melphalan, and it works in myeloma, relapse and refractory myeloma patients, refractory to either pomalidomide and nor daratumumab, so heavily pretreated myeloma patients. Approximately 30% of the patients responded.
31 they said, yeah.
And so I have a personal experience with this new agent that I can say that it works, especially so I've seen dramatically response in patients with extramedullary disease, and in fact the performance status of the patient significantly improved just after the first infusion.
Okay,
so I think that it's a
something
new
to watch
agent
for sure.
that yes, that we can maybe consider as a new agent that we can use along the course of the disease.
And so any hot topics that you that we haven't touched on?
Well, very quickly, two things. Just to
Yes.
emphasize the selinexor story as you've described. I mean,
Yes.
I think we're seeing it, as you mentioned, in that single agent and the so-called penta-refractory patients
Right.
have been exposed to almost everything. But it was encouraging to see its combination with daratumumab, with bortezomib. So I think with time, it may be, as Marie-V said, with a different mechanism of action. You look at that group that we described who go into MRD negativity, you may be able to hold them where they're at. But those that are MRD positive, we need something different. Those patients are not going to be cured with what we have right now alone, and we pursue it.
So that's interesting, yes.
The other wild card, maybe completely a wild card out of the box, Brian, but you know me, I have a particular interest in our communication with patients.
Right.
There were several studies that, and I think this is heralding more in the future, that looked at patient preferences.
Yes.
And how there's a huge variety of patient preferences, so we need to know as a physician historically what we thought was different than what nurses thought, which was different than what patients thought.
Yes.
So to learn their idea of what's more important to them in terms of frequency of administration or certain side effects that they look for. And then, of course, the communication piece. You know, we've seen this theme.
Shared
absolutely.
Yes.
And then when the patient is included, they're more likely actually to be successful and even affect their survival.
Very positive thing.
So I'm happy to see those.
Well,
kinds of
I'm happy that we can actually end on that note to involve the preference of the patient and that shared decision-making process. So really very, very important to discuss what do those things mean, but also to hear what it sounds like to the patient. So this is really very, very helpful. And so for those of you watching wherever you might be here or in the future, we appreciate that. And so thanks to our guest this evening, Victoria Mateos from Salamanca in Spain.
Thank you very much, Brian.
And Dr. Joseph Mikhael. We're very pleased to have had this chance. And